will kick off, and a very, very warm welcome to everyone who has joined us today, and a warm welcome to our speaker, Dr. Pooja Saini. This is the last of the IMH seminars for this academic year, so I'm delighted to introduce Pooja. Pooja is a reader in suicide and self-harm prevention at Liverpool John Moores University, where she leads the Suicide and Self-Harm Research Group. Pooja is also a founder of the Suicide and Self-Harm Research Network Northwest and a co-chair of the International Suicide Prevention in Primary Care Special Interest Group. So today's talk is on suicide prevention for children and young people, care pathways, rapid identification, early intervention and support. And we will follow the usual format of where the Pooja's talk will last for approximately 30-40 minutes. And then we will take questions. So if you can add your questions in the Q&A, I'll be able to pick these up. And Pooja also will be able to, will have access to those. So Pooja, over to you, and thank you so much for joining us today.
Thank you, and thank you for the invitation as well. And it's really nice to hear that I'm closing the ones you've had for this year. So I'm just going to share my screen with everybody. And please just let me know, I suppose, Maria, if there's any issues. Brilliant. I've had the thumbs up. Thank you for that. So I'm here today to talk to you specifically about suicide prevention for children and young people. So I suppose some of my research today that I share with you will overlap into the work I've done with adults, and previously most of my work has been with adult populations, but more and more it's leading towards work with children and young people, and I'll talk about that a little bit more further on. So today I wanted to just talk a little bit about self-harm and suicide rates. I'm not sure, how much knowledge everyone has, so it's just very brief background. Just a little bit about what, we all think self-harm is, when hospital care is thought to be needed, and then going into really what the focus of this talk is about. So the identification and early intervention for people who attend with suicide and self-harm, looking at the current pathways. So we've got a couple of projects going on with adults and young people. So I will discuss both, but more the young people study today. And then just kind of a summary really of the funded research we have going on that overlaps with both population groups, some proposed studies that are coming up, and then some of my personal key ingredients for successful suicide prevention research. So that's kind of the format for today's talk. So what we know is 6,000 people per year in the UK approximately die by suicide each year. And of those, around 200 are children and young people. And for self-harm, there's over 200,000 presentations to A&Es annually, and 40% of all admissions are for teenagers. Now, even though we have some of these numbers that have been published, they all seem to be an underrepresentation for presentations. And we haven't really got accurate data for people presenting with suicidal ideation. So that's some of the work that we're currently conducting that, again, I will mention later on. So approximately 7% of young people have attempted suicide by age 17, and that's what a recent public health survey showed, and 1 in 4 had self-harmed. So the kind of prevalence of this issue is high, and it's only seems to be going up, which is quite concerning. So for people who do self-harm, there's lifelong implications, including personal and social difficulties, increased risk of later suicide, and premature death by other causes as well. So for self-harm and suicide, if we look at some of the data, we want to understand kind of for people who self-harm, who are at higher risk of suicide and who aren't. So who are the people who were wanting to die, and who are people who are doing self-harm to cope with other issues that may be going on. in their life. So it's really important to distinguish between those people, especially when people are attending at A&E. Now, throughout, I've added some visuals of some papers that I think are really interesting, and that just highlight some of the issues that we'd like to look into more with our research, and also try to help provide some solutions for. So if we just look at the title of this paper, really, I think it says it all. Wasn't offered one, too poorly to ask for one. So reasons why some patients do not receive a psychosocial assessment following self-harm. So this is a recent qualitative study that was published by colleagues at University of Manchester. And I think just the title highlights some of the issues we have at the moment, even when people are attending in crisis, that they may not be actually receiving an assessment at that time. And then that will obviously have a knock-on effect for the treatment or therapy they may receive following that attendance. So we know there's a high relationship between the prevalence of suicide and self-harm. 50% of those people who die by suicide have previously self-harmed. Suicide is up 50 times more in the 12 months after attending A&E with self-harm, which then again relates back to this point, is if they're not offered an assessment or appropriate follow-up treatment, it's not surprising to see then why this number may be so high. And 1 in 50 attending A&E with self-harm have died within a year. So all quite worrying facts, really. So what do we consider to be self-harm? I've put here some of the aspects that people may have seen in published research. Mostly you will see overdoses and cutting. I think they're the most common aspects that people might class as self-harm, but there are many other types of self-harm. And then there's also this other group here, which I've added, and I sit on a few boards working with public health and commissioners of hospitals. And there's these other areas as well that we don't think are looked at enough for people attending A&E or generally within the community. So drug and alcohol use, especially amongst boys, you might see more substance misuse, under or overeating. So there's always this overlap with eating disorders as well. Smoking, especially at a younger age when, legally you shouldn't be smoking. Overworking or over-exercising. So it's not always people not doing things, but actually it could be doing things really excessively. And then another aspect that's seen higher in boys is accidents from risky driving. So is that sometimes actually a form of self-harm? So that's another aspect. We're trying to ensure people are looking at much wider range of possible ways that young people may be self-harming, and how to pick up on those things as well, whether it's within the community, within schools, within hospitals. So some common myths I thought would be interesting to talk about for self-harm, and whether people think that they're true or false, really. So I'm just going to go through them one by one. So is it a suicide attempt that they're doing or not when they're self-harming? Is it to get attention? I'm sure many people have heard that before. People who self-harm do not feel pain. It's only teenage girls and doesn't really happen amongst boys. It's only done by people who have a personality disorder or who have been abused. It is done to be cool, so kind of following the pack and as part of a group. If the wounds are not deep, it is not serious. Self-harmers can just stop if they want to. It is done to hurt or manipulate others, or copycat behaviour. Now, the reason I've put these myths up, which I personally, from working within the field, know these are myths, but the unfortunate aspect is you still hear about this till today for people who attend in A&E, possibly in school as well, where they're not taken seriously, and some of these reasons might be brought up about self-harming. I've also heard from school people may say, well, that child's always smiling. So how can they be distressed? How can they be suicidal? Or there's no way they're self-harming because they're always smiling. And I think there's just these myths behind. And I think one thing I've come across within working within the field and research is that people aren't listened to necessarily, even when they're communicating that this is how they're feeling, or these are the behaviors that they're currently using to kind of, you know, relieve some of their distress. So when is hospital care needed? This is kind of a debate, I think, across different organisations that is viewed quite differently. So what the kind of guidance says in our local region is that if a young person needs immediate emergency physical health assessments or treatment, or cannot be kept safe, they should be supported to attend A&E. There they should be triaged, and under 16 should have a different triage area to the general emergency department. Now, we have seen that in all A&Es, where they are trying to move people to other parts of A&E so that they're not with all the people coming in with physical health issues. I don't know if that's actually working in practice, but I do know it's something that has been intended for a while. And then they may be a crisis care team who will see all children and young people in A&E. So if it's not an emergency, then 24/7 crisis lines should be called for advice and guidance, or access for the young person should be either virtually or over the phone. So I'm not sure if everyone's aware of crisis lines. I know this isn't just a local thing, but across the country, especially when the pandemic started last year, crisis lines were brought into play for most hospitals. Now, for hospitals that aren't children's hospital, the line is available for all ages, but for children's hospital, obviously it's just for young people. Now, these were in the pipeline anyway, but because of the pandemic, they were brought forward much quicker. So we'll have a little discussion about that later as well from some of the local research we've conducted up to now. And then assessments should follow the same principles for adults, include a full assessment of the family, the social situation, family history, and safeguarding issues. Now, as we saw before, not all people who attend A&E will have a full assessment. I definitely don't think there'll be this wider assessment for everybody where family history, social situations may be looked at. The reasons for why everyone may not have a full assessment are probably varied across all hospitals and A&Es. And again, this is what some of our research is hoping to find out more information about. So if we're thinking about identification and early intervention, we know that children and young people are highly vulnerable to finding themselves in a crisis, and rates in these groups are increasing year on year. Self-harm is an increased risk factor for later suicide, as we mentioned, and that's the same with children and young people. And 52% of young people who died by suicide had previously self-harmed. So again, that's in line with the adults. With 75% of lifetime cases of mental health conditions having a first onset, many have had their first onset by the age of 24. So it's clear that childhood and adolescence is a particularly crucial time for early intervention. Now, when we look at costs related to self-harm episodes, that's also higher for young people. And one thing we'll look at later is about readmissions for self-harm as well in hospitals. And if we're looking at the national NICE guidelines that are available with the Department of Health, they require that if a young person's seen in A&E and if they're admitted, or if there's, this is causing a huge strain on the NHS. But what we do know from evidence further in the talk is that everyone isn't admitted. And there's also, lacking evidence on the effectiveness of interventions for this age group as well. So I just wanted to include this quote here. Healthcare services and systems need to be better equipped to detect and manage illness from point of presentation to emergency departments through to ongoing care. And I think this is really important because, you know, from what I've just been showing you snippets of, that's not necessarily what happens in reality. So we're aware that A&Es are often the first point of contact. For some people, it may be primary care, but for many, it's presenting in A&E. And as I've mentioned, you'd normally get an assessment, and then you'd have some treatment, and then that would be looked at over time with follow-up, or that's what you'd hope. There isn't, though, a detailed examination of this data to date, and we don't know what the most beneficial pathways are for individuals in crisis. Now, one of the issues here is about the recording of people who attend in suicidal crisis to A&E, and it's not coded as well as people who attend for actual suicide attempts or self-harm. So again, I'll be presenting some findings further on from a study that we've conducted recently. So there's a growing evidence that's highlighted the potential harmful consequences as well of some of the, you know, long-term outcomes of admissions to hospital, and that's for both adults and young people. But then there's also evidence as well for people who haven't been admitted to hospital, when that could have actually been really helpful to them. So we need more research on the facilitators and barriers of accessing support services and the utility of specific policies as well. So we'll talk more about policies and what's available later. So as I mentioned, we're doing one PhD study in adult services. Some of them cross with adult and young people, and some of them are just for adults because there's also a local children's hospital. And what we found within the PhD up to now, the data's not been collected, but from some preliminary conversations with the people who are leading in suicide prevention in A&Es, there's a real kind of differentiation between how suicides might even be recorded, like people coming in suicidal crisis. Some people are recording it maybe as self-harm, some might be recording it as anxiety, some may be recording it as depression, and others in children's hospital, we see it's recorded a lot as social difficulties. So there's a real lack of consistency with how this is recorded across A&Es, and we've only had preliminary conversations with a few, and there's still a few more that need to be spoken to. We've also got a systematic review that's looking at the effectiveness of school-based interventions for self-harm. And part of that will be also looking at these pathways between schools and hospitals as well. Another aspect of study that we're looking at, which is led by Alder Hey Children's Hospital here in Liverpool, is on young people's presentations at A&E for self-harm specifically. And they're looking also at a lot of admissions for specific kind of comorbidities. So it may be with people who've had a history of abuse, or young people who are using alcohol or drugs. So there's quite specific pathways that we're looking at for young people there. And finally, we're looking at young people's presentations at A&E for suicidal crisis. So we're looking at how it's coded, the admissions, and the resultant care pathways. So I'm going to share some of the findings from this work. So this is preliminary findings. It's not published at the moment, so I'd appreciate if this isn't shared too widely, because we will be looking to publish this later this year. So for the whole sample, I just wanted to highlight for 2019 to 2020. So it's March to March, basically. So it's pretty much when a year before the pandemic. Currently, our researcher is collecting the data for 20 to 21, which is the year of the pandemic that will be there. So for this data, we're looking at pre-pandemic. And as we'll see, the data is still significant, and we are hypothesizing that it may actually, you know, get worse kind of for the following year. So 1 in 5 of the young people who attended with suicidal ideation and self-harm, 2/3 of the attendees had a history of self-harm, and 2/3 of the young people were known to CAMHS, and over 1/3 were referred to CAMHS. So we're not, we're going to look at the data in more detail to see if these are the same people who were referred to CAMHS are the ones that were already known to CAMHS, or the two different groups. Over 1/3 had mental health issues. We're not sure whether it's a diagnosis or whether it's just come up in their consultation when they were presented at A&E. 1 in 5 had special educational needs, and 1 in 5 had a diagnosis, and 1 in 5 had ASD traits as well, so autism traits, but they weren't diagnosed. And again, we need to have a look at the overlap between these two groups. Nearly a half reattended at A&E within the same year, so that's something I spoke about before, about how high readmissions might be. And for some of the people who reattended, they reattended up to 12 times in a year. It wasn't just one reattendance. And the reattended that we looked at was for people who reattended for self-harm or suicidal crisis, something related, not just general readmissions. Half the sample lived in single parent households, either with only a single parent or with siblings and within a single parent household. So that number was much higher than we expected. We also have started to look at gender differences. So we found that 2/3 of the attendees were female. On average, the males who attended were slightly younger than females, so it was 13 and 14. So not too much difference. Females attended more with suicidal ideation and self-harm, and females were more likely to have a history of self-harm, and females were more likely to be known to CAMHS as well, and to have mental health issues. Males were twice as likely to have special educational needs, but one interesting finding that we saw was that females were more likely to have ASD traits. So they were less likely to have a diagnosis, but more likely to have traits. And I think this is quite interesting with a lot of the news that's been going on at the moment to do with females being diagnosed later in life, whether it's in their 20s or 30s, with autism or ADHD or other similar health issues. So this finding we thought was really quite interesting, and we're going to look at the group of people who came in with special educational needs in much more detail since looking at this data. Females were more likely to be readmitted to hospital for suicidal ideation or self-harm as well. So I don't know if anyone has seen anything that was unexpected, but please ask me any questions at the end. I mean, it is really just a snippet of the data. So another study I just wanted to mention to do with children and young people is from the Share Now group. So that's the suicide and self-harm research group that we have in the Northwest. That was started in 2016, 2017. And within the first conference, we did some workshops in the afternoon where we looked at which population groups were the priority groups for people. And one of the 4 groups was children and young people. The others, just for information, are offenders. There was crisis care in the community and self-harm as well. So you can look at all the groups in more detail with the paper attached. But I just wanted to highlight the work we did to do with the research priorities for children and young people and what came out of the Delphi exercise. So understanding different ways to build resilience in children and young people to help reduce self-harm, understanding help-seeking behaviour in young people who self-harm and barriers to accessing services, evaluating training programmes regarding self-harm for those who work with young people in non-clinical settings, so for example, teachers in schools, and then finally evaluating the efficacy of interventions. So for young people who self-harm, like talking therapies, mobile apps, and support groups. So I just wanted to highlight really, firstly, how high people rated that these issues were important, who took part in the Delphi study, and we had quite a good number of participants who did take part for the Delphi study. And we've tried to build on these research priorities with all the research that we're now currently doing. But I think if we look at the second point of understanding help-seeking behaviour in young people who self-harm and barriers to accessing services, with what I've kind of shown today is a lot of young people are accessing services, and that's probably only scratching the surface. But for the ones who are accessing the services, they're not all necessarily being assessed. Many of them are coming back, so we need to understand why they're coming back and being readmitted. Many are being referred to CAMS or on waiting lists for CAMS. So we need to understand really what's happening with some of the data, and whether people accessing services are then being provided with the help and support that they need. So just to give a brief overview for some of the funded research within our suicide and self-harm research group at Liverpool John Moores, even though some of these projects are focusing on adult populations, what we found is many of the people being referred in for either the trials or the service that's available now in communities are young people. So kind of young adults, if we put it up to there, so up to the age of 25, 30, and especially students. But even for the adults who are attending within some of these services, majority of them talk about the onset of their self-harm or suicidal crisis, kind of thoughts and behaviours starting in adolescence when they were in school. And, when I started this presentation, I mentioned that most of my research actually started in adult populations, and now I'm moving more towards children and young people. And one of the reasons for that is the amount of people who've spoken about the onset of their kind of self-harm and suicidal crisis issues starting when they were actually school age. So that's what's kind of moved the research in that direction. So just to go over a couple of the kind of new innovative projects that I'm involved in. So one is the community outpatient psychotherapy engagement service for self-harm, which is delivered in primary care. So people are actually, they are recruited for the project from primary care, but they actually receive a therapy that's delivered by secondary care services, by the mental health trust. So it's quite a unique project in that we're working with both groups together. So the mental health trust and primary care very much have to work together for this project. We've currently recruited a third of our target, so 19 out of 60 people have been recruited, and we've got people in both arms of the study. So within that study, they're receiving a brief psychological therapy where they have 5 sessions with a trained therapist in the COPES therapy. And then we're following up with them every month for up to 3 months. The preliminary findings, again, are showing that this intervention is really positive for the people who are in the intervention arm, but we haven't done any of the comparisons yet because we're waiting for all of the data. We're also evaluating a self-harm training, and that's called a toolkit as well, but I wanted to distinguish between 2 different projects. So the self-harm training is where a training has been put together for people working within mental health with young people, and it is targeted for schools. And it's whether that training, once it's provided, to give people more insight about what self-harm is, what it might mean for young people, how to incorporate young people within their school, to possibly get involved in the co-production aspect of how to manage self-harm in schools, and how to help teachers or safeguarding staff on how to manage when young people do come and communicate about self-harm. So we're going to be doing an evaluation of that in Liverpool, where it's been delivered. And then there's the self-harm toolkit, which is actually a physical toolkit that will be given out to young people. And it contains numbers for help. It contains some practical help for them. It contains some medical things, plasters and wipes, if they do need that, if they're self-harming. And we want to look at the effectiveness of when they do come and report about self-harm, whether it's in schools or other settings. There's 9 settings they're going to be looking at, and it's for young people and adults, is how effective these small self-harm toolkits are for people and whether they do access support after them. The other project, which again, it's adults in the sense of over 18, but it's university students who I think really fall in between young people and adults. And I think it is right to still class them as young people for our research purposes. And that's looking at a similar type of therapy, but it's delivered with university students. Now, it's delivered on campus by staff who are trained. And the difference with that one is it's not like a study. There's not a control arm and a comparative intervention arm. It's a service that's being delivered and trialed. Again, it's been very successful. They've had students attending and they've not dropped out. They've attended most of the sessions. They found it very helpful from preliminary findings, and the local mental health trust are looking to potentially recommission that to be a service available within university settings. So as you might see with the research I'm involved in, it's very much moving some of the interventions and therapies or services to be based out of A&E and out of hospital settings, even though they may still be managed and commissioned by the people who traditionally would have been in hospital settings. There's also the James Place Service evaluation. Again, this is for adult men, but a lot of people attending. So, 20 to 25% of the men attending are students. So there's a significant number. And in the new London service, they're doing a lot of work aligned with universities, just like Liverpool did. One of the reasons for this is because the James Place service came round when a boy called James died, who was attending university when he died. And so his family, who have funded these services or have done the fundraising for these services, were very passionate about there being service availability for people at university, young men, especially at university. But I think it's just showing as well that there is a real need for university students. Another study that colleagues of mine are leading on are the long-term impacts of COVID-19 for children and young people with special educational needs and disabilities. And I think we've already started to see some overlap with some of the work we've been doing with Alderhay Hospital on people who attend for self-harm, and with this project here. Now, this has been open for a while. Some of you may have seen us tweeting about it. And the NIHR funders thought they may only get 100 people completing questionnaires. And I think for one of the questionnaires, they've exceeded 600. And every element has just had unbelievable recruitment numbers. So I think it just highlights really what an important issue this is, and what an important area that this is. And one thing we're finding within our group is there's a huge crossover with special educational needs and disabilities and self-harm for young people who are attending at A&E. And we're also doing some qualitative studies with parents and teachers on the impact of COVID, and with service users with complex mental health needs in out-of-area placements. And now, again, this project is obviously looking at people who have had a complex relationship with health services, especially to do with their mental health. And many of these, when we're looking at their in-depth case notes, their issues started again when they were school age. So I just find with many of the projects, it does come back to that. And finally, we've got a PhD looking at post-vention services for people who've been bereaved by suicide. And again, there is this nuanced focus on whether it's families, whether it's children and young people, whether it's schools, So people working with children as well, if something happened in the school community. So there is, again, nuanced work with children and young people there. So I just wanted to mention some proposed studies. Again, these have been submitted for funding, but they haven't been funded yet. So it'd be great if this can't be shared too widely. But a colleague and I, Dr. Emma Ashworth and myself, have submitted an application where we're going to look in more detail at the care pathways, the rapid identification services and interventions and support that's currently available. So we're looking to examine the current care pathways, which we've already started to do in some of these other projects, and look at how identification occurs and whether it's kind of streamlined or there's consistency, or whether it's quite different across services. We want to look at what current interventions and support are available for people with mental health crisis. And what we do want to do, which is quite nuanced, is we want to look at this across the life course and not just for children or young people or adults, but actually look at it across the life course. So we think this study will have real world impact via collaborations with partners working in this field as well, and with our wider stakeholders. And we're very passionate about including people from all aspects of social care, healthcare, local authorities, and public and patient involvement within all of this work. So another application that's been submitted is looking at these interventions I mentioned before, so the brief psychological interventions, but within a school setting, and to have these kind of align within these whole school approaches for mental health. So we've tried to put in a specific pathway for self-harm within schools. So this is currently submitted as well for a stage 1 funding call that was out recently. And we're working very closely with YPAS, which is the Young People's Advisory Service. There are, a third sector organisations like this in other areas as well, but we do know from the work we've been doing in Liverpool that the service in Liverpool is really successful with some of the outputs they've produced, but the demand for the service is way too big. So we're looking at kind of working with them on how to provide some specialist services for young people for self-harm, but we also want to know where is the best place for these to be held. Should they be offered within school? Should it be within hospital? Should it be within community? So we're going to look at different sites, and we're going to have pupils involved in this as well. So the final thing I wanted to touch on before I finish is that our group has been looking at the impact of COVID on young people's mental health and schooling. Now, I know this isn't specific for self-harm and suicide prevention, but I think it's really important to see what effect has been had on people's mental health over this time. So we asked some schools to get involved to share a survey with 11 to 14-year-olds. So it was years 7 to 9, to the first 3 years of secondary school. And we shared online surveys and then invited people to participate in interviews, so they could tell us at the end of the survey if they wanted to be part of an interview. Again, we've got more papers than this actually available in preprint now, but our reports available online too. So some of the key quantitative findings that we found was that those within a key worker family had higher levels of well-being than those who didn't know, and they had worse outcomes for their well-being. We found that with households, like if households had more difficulties, they were significantly related to lower levels of optimism and well-being and higher levels of mental health difficulties. So I suppose that's not an unsurprising finding, but again, that's what the survey data showed. There was a greater fear of COVID related with lower optimism and well-being and greater mental health difficulties. There was higher COVID knowledge was associated with greater adherence to lockdown rules, but not mental health or well-being. And young people who completed the survey after the introduction of tier 3 measures in Liverpool. So Liverpool was one of the first places to go back into kind of a mini lockdown after the first lockdown, and they had significant lower levels of optimism. So we looked at the before and after that local lockdown was put in place, and then help-seeking intentions related to higher optimism and lower emotional difficulties. So, you know, people who actually looked to get some help would have high optimism. So we also did some qualitative interviews. So I just wanted to go over some of the findings from there. So it's the last few slides now. And just to highlight some of the quotes that were brought up. So this was to do with challenge, change and loss. So we heard this a lot, life is weird. And that was a word that young people brought up a lot at that age. Many people talked about missing their family and friends. Many were quite mature about how they spoke about the government handling and about some of the other issues that were going on, you know, in the world, like Black Lives Matters. Young people spoke a lot about feeling safe and the fact that the news was quite scary to them. Some people also spoke about being quite worried if their families worked in some of the frontline key worker jobs as well. So if we just go on to the next theme, so looking for the importance of school. So there was a clear, you know, from everyone, preference of being in school. They missed just having the teacher there in the classroom, and they really felt segregated from them working at home when they couldn't put the hand up, or they couldn't just ask the teacher, or maybe the teacher would be able to read on their face that they just hadn't understood something, and they really missed that side of it. Many of them had worries about how they managed schoolwork, even though they seemed to be doing the work. So it was quite interesting that the young people who did participate did seem to be keeping up with their workload, but they were still very, very worried about it. Many found technology was a challenge, especially if computers kept going off and on and not being able to have a clear communication. Some enjoyed the freedom, and many of them were still unsettled who had started going back to school. And it was especially hard for those people who just joined secondary school, who were in year 7. So some of the positive things of lockdown, there was a real conscious effort from young people to actually, you know, take care of themselves and how they coped with being in this situation. And many of them talked about the new hobbies and skills they'd learned. But the biggest thing that was talked about was spending more time with family, and especially with parents. And that seemed to be a real positive aspect for many young people. And young people spoke about strengthening relationships, whether that was with their friends or their family as well. And for many of them having quite a positive and resilient mindset. So I just wanted to finish off by talking about some things that I think are really important in research, and I probably haven't given enough time to, but I could have given more time to a lot of aspects within the research. So what do I think is important? This isn't necessarily everyone's key ingredients for successful suicide prevention research, but for me, from my experience, I think it's these things. So I just wanted to bring up a couple of aspects. So one for me is co-production with all relevant stakeholders, including children and young people. And that's something we've been really, really mindful to include. I mean, the funding application we recently put in, much of that is for working with the McPin organisation so that we can get young people involved in the work as well. Changing the kind of attitudes of ethics for research, suicide research. So we've had a lot of issues over the years about doing research with young people. And I think there needs to be a change in mentality on the, actually, it's more unethical not to involve young people in the research that we're doing. And especially when a lot of people talk about the onset being in childhood. guidelines for suicide prevention in young people. Maria McHale, who's on the call, has been involved in some guidelines as well, which I think have been really useful, especially to do with primary care. And we're also working together for suicide prevention in primary care as well, more widely. And then I think suicide prevention in schools is vital, and we need to increase that. And I've included some of the work that's been going on with our Australian colleagues, which we're hopefully going to replicate some of that work and work with them more closely in the UK. So I'd just like to acknowledge and emphasize that we work with a lot of collaborators. These aren't even everybody. There's more people we work with, but just to say a big thank you to everyone who's involved in all of these research studies that I've brought up today. And that's everything from me. So if you have any questions, please let me know. Thank you. I will just stop sharing now.
Wonderful. Pooja, thank you so much for this excellent presentation. A real sort of a very good snapshot of all the important work that you are involved in, both across sort of clinical services, but also community settings. And I know you've got a real passion for community-based services in suicide prevention, don't you? And that's reflected in the special interest group that we have as well. So thank you very, very much for this presentation. So we've got 15 minutes approximately for questions, so please feel free to post your questions on the Q&A, pressing the Q&A button on Zoom. And can I start off, if that's okay, Pooja? I've got a couple of questions, if that's okay. You know, the very interesting preliminary data that you've shared with us from A&E attendances, and I was wondering, do you have any information on ethnicity?
We do, and majority, it was 95% white populations. So
okay, that's interesting.
So we have got some data, but it's so limited. And when I say 95%, that's from the people who'd completed the ethnicity data. So it could be higher, but from the recorded ethnicity, it was very, very high. So we couldn't do as many kind of comparisons as we'd hoped, actually.
Yeah, absolutely. We've got one question. We've got one question from our attendees. What do you think educational psychologists can do to promote good practice within schools to support their children and young people?
Well, that's an interesting question. And the reason why is because in some of the work I've done with Alderhay, we've actually had educational psychologists as part of our team. Now, I'm not sure how many people kind of know where they fit within a system, if you like, but for the ones I've spoken to, they've been quite early in their careers, the ones who are based in school. So they kind of graduated psychologists who've then done some training and become educational psychologists in school settings. The feedback they've given is that many young people are coming forward for support in schools, but they're recruited to manage low-level mental health needs. But many of the young people who are coming forward for support haven't got low-level mental health needs. They've got moderate to severe. And so then they're quite limited in what they can do for these young people. So I think it's a really interesting question, because the educational psychologists I've spoken to have said they'd like to do more, and they think they should be the ones maybe who get some of this training, because they see a lot of young people who come in for self-harm, but they're actually not allowed, if you like, within their remit to handle that. So those people have to be stepped up then and referred to CAMS. But with the proposed study that I spoke about in schools, one of the roles we've suggested is that maybe it's the educational psychologists who get trained to provide this therapy. So I think they want to do more is the answer to the question, and I think their hands are tied a little bit. It is my point. So I think it's brilliant that they're in schools, but I don't know at the moment how much they can do.
Okay. So we've, can I ask, the data that you have collected in an A&E study was pre-COVID, is that correct? Yeah. Have you been able to compare and contrast with data with what's happening during COVID?
So that's all just been entered literally last week, and we're waiting to be able to get the comparison. So what our research has told us is that the numbers are just as high. They may be higher, but there's not huge differences between the two. But one thing there is definitely a difference in is the crisis line data. So like the number of calls that were made to the crisis line in 2020 since the pandemic started. So if you look at March 2020, it was much lower than March 2021. So for a certain period of over the year, it was 700, whereas in March 2021, it's 700 alone. So the calls to crisis lines have gone up hugely. One thing that was brought up is that many people are calling for social issues, and parents are using the lines a lot for support and help, and same with young people. So that's one thing we definitely do know.
Yeah, and that's really interesting. But I think that tallies well with previous research that has been published during the pandemic, looking at A&E presentations in relation to self-harm. And I think what we have seen is perhaps a change in help seeking. So we've been working very closely with the NSPCC, for example, and calls to Childline in relation to suicide and self-harm have rocketed during the pandemic.
Yeah. And I think, I can talk on some personal stories, which again, I really wanted to include, but it's like how much to include. But if I talk about one person who's involved as a public advisor in our research groups, now their daughter has been struggling through before the pandemic, but throughout the pandemic time. And I know for them, because they can't access the support they need, they're kind of going to every avenue. So whether it's the NSPCC line, whether it's a crisis line, and I think everyone's trying to ensure they get the right support, but then they've been referred to CAMHS, but then that was rejected because of some reasons. Then the GP has said it shouldn't have been rejected and referred them back. And there's a lot of that going on. So it just feels like it's very complicated. And I think the crisis line is really useful for some people as another resource, but I think unfortunately it's sometimes classed as the only resource. So I think some of these new resources are really good, but not as an alternative altogether.
Yeah. And the thing, I mean, if we had our sort of a colleague on the phone, Karen Newbigging has done a lot of work looking at crisis care pathways, and now actually, and I was wondering, are there any parallels with this work? I think it was also funded by NIHR, looking at crisis, not in young people, but in adults.
Yes.
Crisis care pathways in relation to mental health crisis, and the particular role that the voluntary sector might be able to play or plays.
Yeah, I'll be honest with you, Maria. I'm sure we've probably cited it, but I'm not sure off the top of my head. I'd have to have a look, to be honest. But I know we have had, I think, PhD students on this here today, but I think since we have tweeted about some of our work, we have had a few other groups get in touch about actually looking at the work we're doing and the work they've done or are doing as well. So I know there's definitely some parallels with some partners across.
Absolutely, I'm sure there will be synergies. Yeah, wonderful. Yeah.
And let me know if we haven't. It'd be good to know those.
I think the report has been published, but we've got 2 questions. CAMHS waiting list is incredibly long at the moment. Is there a potential, aside from our dimension in relation to educational psychologists, for someone else to deliver interventions to children and young people? Surely some intervention is better than none.
I totally agree. And within the project we're proposing, there'd be different people who'd be trained up. So even for the COPES project that we've done within community settings, we were asked as well to train up different staff, within mental health, so that there can be that comparison made of actually who are the best staff. Is it the psychologists? Is it mental health nurses? So I think it should be a wide range of people when it comes to self-harm and suicide prevention. But I think the problem with people who've had just mental health training is it's not nuanced enough for self-harm and suicide. So it's just getting the balance of having enough people trained and that distinguished difference between the two. So the training we're providing really is to people who've got mental health training in some capacity, and it's kind of an extra element, so a specialism, if you like.
Wonderful, thank you. We've got another question. What is the current gold standard for interventions, and is it applicable internationally across different cultures? I might have missed this. So I think what is the gold standard for interventions? I think you're referring to self-harm, but please correct me, Arthur, if you're not. So what is the current gold standard for interventions in relation to self-harm, and is it applicable internationally?
Well, I suppose if we're looking at the gold standard, I think it'd be randomized controlled trials that are classed as a research gold standard, if we were talking about the research aspect. Now, is it within schools or just?
I think it's probably a more general question. I think it's probably more what works for self-harm, and I think probably if we're referring back to a very recent systematic review, probably very little at the moment.
Yeah, yes. Well, we're doing a systematic review specifically on schools internationally. Most of the work we've seen has been conducted in America or Canada. So we're looking at those. Some is being conducted in Australia as well. For me, the key, I think, is involving young people in the co-production of the work, and it not being kind of top down, but actually coming from the roots of the people who need the support and need the help. What do they need, to help them?
I think there's been a recent systematic review about what works in youth suicide prevention by our colleague Joe Robinson in Australia.
Yeah,
identified a great potential in terms of primary care and capitalizing on the role of GPs in suicide prevention. School settings to a certain extent, but I think one of the things that Joe's review has highlighted is the role of digital interventions. Yeah,
actually, I think that's a really good point, and it's something that the group is looking at as well, is mobile apps and aspects. But one thing that came from some preliminary work we did with university students was that they said we don't want mobile apps instead of a person. So
Absolutely.
I think and I'm saying more from just reading myself and not actual research that I've conducted, but it feels like digital health is really powerful, really helpful, but alongside some of that contact that people still need, even if it's remote therapy. I think people still want contact with a person.
Absolutely, and I think this is what we're hearing from young people as well. I mean, digital intervention, particularly for self-harm and suicide prevention, should not be a cheap alternative.
Yes,
should be adjacent to face-to-face services. Yeah, absolutely. I'm seeing if there are any more questions. I think that's it. I'm mindful of the time, and I don't want to keep people longer than what we said. So with this in mind, Pooja, a big thank you for your time today. An excellent presentation, and wonderful to see the breadth and depth of work that you're doing with your research group. So thank you very much for joining us today, and a big thank you to our attendees as well.
Thank you again for the invitation as well.
Wonderful. And this is, just to repeat, the last of the IMH seminar series for this academic year. We will be back in September, and we will circulate details shortly. So again, a very big thank you, and I hope you all have a good afternoon.